Good evening. Hematology, as you know, is a branch which blends, like in most of the other clinical medicine, the art and science of medicine. Most of us have seen so many hematological, especially anemia cases, and sometimes just giving an iron tablet will not cure the patient, as you know. Sometimes the cause is difficult, sometimes it is easy, and we have a hematologist here to discuss the different scenarios in hematology. And it's my pleasure to introduce Dr. Rajesh Krishna. Dr. Rajesh Krishna studied MBBS from Government Medical College, Calicut. It's 1992 batch. He's my batchmate. And MD General Medicine from Madras Medical College. He then went to United Kingdom and completed MRCP UK. He initially trained in hematology in Sheffield, following which he got selected for 5 years higher training in prestigious London rotation, during which he obtained FRCPath and CCT in hematology. He was trained under world-renowned experts in Imperial College, MS Trust, and University College Hospital, London. He is an expert in managing blood cancers like myeloma, lymphoma, and leukemia, apart from general hematology and hemostasis. He is the first person to perform cryopreservation of stem cells for lymphoma bone marrow transplant in Mangalore. He is practicing in medical chambers where his father, late Dr. V.N. Bhatt, urologist, practiced. Many of the senior members might be knowing his father, late Dr. V.N. Bhatt, who was a retired professor and head of the Department of Urology, Calicut Medical College. I welcome Dr. Rajesh for the speech.
Okay.
Good evening, everyone. Thank you very much for your kind words, Manu. I have fond memories of living in Kannur for 3 months when me and Manu locked ourselves up in one lodge to study for PG entrance examination. This was many, many years ago. I also express my gratitude to the IMA President and Secretary and the IMA members of Kannur for inviting me to speak on a topic in hematology. What I have decided is to talk about a few scenarios briefly so that it interests everyone. So, hematology is one of the few branches in medicine where you are both a pathologist and a clinician because it goes from the lab where we look at the blood smears, which is peripheral smears, to the bone marrow, and then go to the bedside and treat the patient. And we are also a branch of medicine where we treat both benign as well as malignant disorders. We also treat thrombosis and also at the same time bleeding disorders and also perform bone marrow transplant. So it is an extensive field which involves pathology, clinical medicine, thrombosis, general malignant transplant, etc. So I will go straight to a few case scenarios. So these are cases that I have seen in Mangalore, where I have been practicing since 3 years. So rather than bringing up cases from UK, I thought we will discuss with the cases that I've seen locally. So this is a 78-year-old man who was admitted in ICU for chest sepsis and a few other medical problems, including diabetes, hypertension, etc. His hemoglobin dropped unexpectedly from 11 to 7. And that was very clear. There was no bleeding, nothing. So hence I was called or I was given a referral to see this patient. What I found was the bilirubin was borderline. See, if the bilirubin is high, then we will think of, okay, patient has hemolysis, but it's borderline. Again, LDH is rises in hemolysis. That was also very borderline. Then we have things like iron deficiency, B12 deficiency, they are all normal. And then I noticed that the patient was on antibiotics for infection. So as a hematologist, the first thing I do when I get a referral is ask for a peripheral smear. Now this is a very cheap test. And which almost all of our patients can afford. And many times I like to see my own peripheral smears because I can put a clinical, I can give a clinical input on that and look for the things that which I think may help me to get a diagnosis. So this peripheral smear interestingly showed few interesting cells. Now I've written the name of the cells, that is called bite cells, which essentially looks like something has been beaten out of the red cells. So now this clinches a diagnosis. So this is an inexpensive test, which shows why this patient had breakdown of red cells. And this happens in oxidative hemolysis, sometimes in G6PD deficient. Now, this patient has already been transfused, so we cannot assess G6PD in a transfused patient, so we did not do that. So what I did is I looked at the drug list to see whether we could stop a few drugs. So I stopped these antibiotics, and then he improved. So often drugs like nitrofurantoin, quinolones, are the culprits. So this is an interesting scenario where a cheap test led to a diagnosis. Now a second scenario, this is a 75-year-old lady. Now, like many patients, they come and say, I have never been to the doctors in my entire life, and now she's been tired and dizzy, and now she has come and got admitted with what looks like pancytopenia. Her hemoglobin is low, white cells are low, platelets are low. Obviously, the liver and kidney functions were normal. So, in case of a pancytopenia like this, again, first thing I look at is peripheral smear. Then I decide whether we need to do a bone marrow test or other tests. Now, interestingly, I saw this cell in the peripheral smear, and that is what is called a blast cell. Now, blast cells are seen in hematological malignancies like acute leukemias, can be acute myeloid lymphoblastic or myelodysplasia. So we ended up doing a bone marrow in this lady, and the diagnosis was myelodysplasia. Now, myelodysplasia is actually a neoplastic condition, but it's not like a frank overt cancer. So this is a condition where the bone marrow is not working properly, dysplastic. That means the cells are abnormal and it is sort of slowly moving towards malignancy. So we have steps to classify the types of myelodysplasia and decide on treatment. If it is early myelodysplasia, sometimes supportive care with blood transfusions and some drugs like erythropoietin may help. And this lady actually benefited with the erythropoietin, but eventually we decided to give her other drugs like what is called hypomethylating agents, which is a type of a gentle chemotherapy because she's quite elderly. We can't give her high intensive treatment. Now, I just mentioned another patient because again, sometimes we have got drugs called hypomethylating agents, which are quite gentle, not intensive chemotherapy, more gentle drugs, gentle injections, which can sometimes help patients and help them to go towards remission. And we give them in combination with the erythropoietin and other supportive treatment. So, I've decided not to discuss in great detail about these diseases because rather highlight interesting cases. So this is another case where I was called to see the patient because the hemoglobin had suddenly dropped to 4.8. Now the history is the patient had undergone a recent valvular surgery. creatinine and bilirubin was rising. So look at the peripheral smear. Now what we are seeing is the arrows highlight towards the fragmented red cells, and they are called schistocytes. So obviously something is breaking the red cells, and if a patient has had a valvular surgery, we think probably there is some leak in the paravalvular leak, or it may be sometimes just a stitch standing out, which is causing the red cells to break down. So in this lady, again, she underwent echo and other things, and they thought that there was probably a small leak. She was not willing for any further surgery. Now, our diagnosis was valve-related hemolysis, and the renal damage was because of pigment nephropathy, because of the hemoglobin that was filtered by the kidneys, causing damage to the kidneys. And usually they need a valve replacement. But this was a very unusual patient because he declined any further surgery. I thought I'll add some steroids and see whether there was any response. And she responded. So there was some autoimmune component also in this lady. And she responded to steroids and mycophenolate. I'm going to another case. So this again was a referral from a physician where a patient had persistent thrombocytopenia. Platelet count was 30,000, and the patient was fine, no problems at all, no history of bleeding, no petechiae, no bruising, nothing. But like our patients, he was just eating the head of the physician saying, what is the reason for low platelets, what is happening. No cause was found also, and hence this patient was referred to me. Peripheral smear was looked at, and what we are seeing is clumps of platelets. Now, when I say clumps of platelets, what it means is that the platelet count in vivo is normal. So this is an artificial phenomenon whereby when the blood is drawn out in a EDTA vacutainer, the vacutainer that we send for the CBC is basically the purple top, the EDTA. And the EDTA causes sometimes in some individuals an artifact, and this is pseudothrombocytopenia. So what we do is we look at the peripheral smear and then recount manually, and then we say, okay, your platelet count is normal or near normal, nothing to worry. Reassure the patient and send them home without any treatment. There is another way of testing. If the blood is taken in the citrate or blue top, then we can estimate in the machine also. So this is quite an interesting case whereby the patient has got no problem, but the machine shows a problem. Now this case I remember very vividly because this happened during the COVID lockdown. A 24-year-old lady, she had recently given birth, was extremely unwell, confused, febrile, in renal failure. The creatinine was some 7 or 8, and they were thinking they were going to dialyze the patient, very unwell, and there was a lot of pressure because a young lady, who was quite unwell. Now, when I saw the patient, I looked at there was already a peripheral smear report, which was reported as normal. But again, that was the importance of somebody reporting without knowing the clinical background. Now I thought, okay, there is a MAHA, there is, thrombocytopenia, renal failure, patient was slightly confused and had fever. I thought this looked like a TTP, which is thrombotic thrombocytopenic purpura, whereby there is a breakdown of the red cells causing MAHA. Why does this patient not have MAHA? And I looked at the peripheral smear. So this time I decided to go and look at it myself. Sometimes I don't, and sometimes I do. And what I saw is look at a lot of fragmented red cells. So classical microangiopathic hemolytic anemia. So basically, for a condition called TTP, which is a medical emergency, because the patient can die due to TTP, thrombotic thrombocytopenic purpura is a full form. There are 5 components: microangiopathic hemolytic anemia, thrombocytopenia, fever, renal failure, and neurology. Now this happens because of a deficiency of a substance called ADAMTS13, and this can be acquired. This happens due to certain antibodies, and what happens is that because of this, the platelets clump in the blood and cause small fibrin strands in the blood vessels, causing breakdown of blood cells. And even though the platelet count is low, there is an artificial, even though it is low, the main problem is thrombosis. So they may die out of a myocardial infarction or a stroke. So this is a dangerous condition. So here we made a diagnosis of TTP secondary to COVID. So we should have published it, but unfortunately we didn't. There are a few other case reports where this happened secondary to COVID. Interestingly, the patient also developed seizures, and the MRI showed a condition called posterior reversible encephalopathy, and that was associated with TTP. We did a plasma exchange, and there was an excellent response. Short course of steroid was given, and till date, this lady has not relapsed, doing really well. She used to come for a year for follow-up, but thereafter has stopped because she's doing really well. So this is a hematological emergency, and again picked up because of a basic simple test, peripheral smear. So from peripheral smear, I'm jumping to bone marrow. This is just a bone marrow picture of a patient with pancytopenia. What you're seeing is the bone marrow replaced by fat. And on the corner, you can see hematopoietic tissue. But this patient had what is called a hypoplastic MDS and responded because of immunosuppression. And again, very elderly patients, we don't give high intensive treatment because of the risk of sepsis and higher mortality. Some of them respond, but some of them do not respond also. Now going to yet another case. So this is actually a peripheral smear of a patient with renal failure and anemia. Now the cells that are seen are called plasma cells. Now plasma cells are seen in myeloma. I mean, most physicians here would recognize that patient with anemia and renal failure, first thing most doctors think is, can the patient have myeloma? Because that is one condition where patient has got severe anemia and renal failure. And often the LFT will show raised globulin. Now, in myeloma, the plasma cells are increased in bone marrow, but this patient has got circulating plasma cells in the blood. Now, circulating plasma cells in the blood, it's called plasma cell leukemia, and the prognosis is very poor. We did give chemotherapy to this patient, but unfortunately, the patient passed away. Now, for the pediatricians here, this is a small child, a 5-year-old child with a hemoglobin of 3.8. Now, here the history is like this. You see, I was about to go home, and suddenly the pediatric PICU PG called me saying, we have got a child with a hemoglobin of 3.8. Can you come and see this child before you go home? Now, what I did is, I said, can you ask the lab to make a peripheral smear? And before seeing the child, I went to the lab because I was worried, can it be leukemia? What is happening? And what we see is these sort of cells where there are like, those blister-like appearance. Now, this is called basically hemighost cells. So very, very interesting cells whereby the red cells are retracted. Now, this again is a classical picture picked up in the lab. Now, this happens if there is a G6PD deficiency. Now, as you know, it's a excellent condition, so more common in the males. Now, this child consumed fava. It's called it's called abrakai. It's fava beans. So a child had consumed that, and that was what led to a brisk hemolysis. The child had cola-colored urine and quite brisk hemolysis. Now, what is interesting is G6PD deficient individuals, what we have to do is, there is no treatment once a hemolysis starts. What we do is supportive care, give blood transfusions and try to catch up and remove the causes of hemolysis. So generally, a lot of antibiotics also can cause hemolysis in G6PD. And one of these talks I was talking about this particular case, and one pediatrician alerted me to say that even sometimes naphthalene balls can also cause G6PD hemolysis in G6PD individuals. So we have to educate the family about what not to give, and also give them a list of drugs not to take also, so that they can avoid hemolysis. This child recovered very well, was in hospital for a few days, we transfused, and then educated the family, recovered well. And I think very interesting peripheral smear, the classical appearance. Now, why I am bringing these particular cases, sometimes, we have these pancytopenia cases. They are not hematological. They are because of other diseases. As you know, pancytopenia can occur because of other causes, non-hematological causes. Now, in this lady, my wife is a rheumatologist. Now, she actually, because of various rashes and other things, this lady came to see her, and then she noticed a pancytopenia and sent the patient to me, and we did a bone marrow, and that shows these granulomas. So what are the white spots seen there are the granulomas, and first thing we could think of granulomas is, can it be tuberculosis, can it be sarcoidosis? So all these tests were done and they were negative, but ANA was significantly positive, and then these are granulomas secondary to sarcoidosis. So the diagnosis is basically, secondary to SLE. So granuloma secondary to SLE. And this lady was treated for SLE and she responded beautifully well. The pancytopenia resolved. So this is two interesting things or takeaway from this lady is that one of the things is that the pancytopenia was not because of any hematological or bone marrow cancer or disorder. And second thing, the granuloma was not because of TB, sarcoid or other common things. This is another case whereby the diagnosis was non-hematological. Lady with unexplained anemia. Now bone marrow showed these clumps of cells which are non-hematopoietic. When I say non-hematopoietic, when we look at a bone marrow, we expect blood-related cells and precursors, but those cells were like non-hematopoietic cell clumps, and this is metastatic adenocarcinoma. And I should confess that I didn't examine her breast, but after this, first thing we went and asked her is, do you have lumps anywhere? And she said, oh, I have this small lump in my breast. And she had breast cancer. So I treat only hematological malignancies. So I referred this patient on to a medical oncologist to manage. This is another, I work in Yenepoya Medical College. Sometimes we get very poor patients from North Karnataka. Now this child is an untreated, he had an untreated lump for nearly 2 years and he was treated with Ayurvedic drugs, and the lump got so big. He had a huge, massive hepatosplenomegaly, and when this child came, he was in cardiac failure and almost about to look like he was going to die. And then we of course, we were sure he had a hematological malignancy, a lymphoma, but before we treat lymphoma, we need a tissue diagnosis. It was Hodgkin lymphoma, and the child responded so beautifully to just 2 cycles of chemotherapy. We gave 6 cycles of treatment. Child is still in remission, and the liver, spleen, everything resolved beautifully. I just put this picture because of the, this is one of the, huge lymphadenopathy in a small child I've seen. So now I'm going to talk about, the disease which I'm most interested because I was in UK for 15 years, and there we are encouraged to subspecialize in one disease so that you know more about one disease when you are working as a team. And I was a myeloma specialist there. So here, this is again, like I mentioned earlier, when you have anemia and renal impairment, you think of myeloma. This is a bone marrow, and the cells that are seen there are plasma cells. And you have some binucleate plasma cells also. And this is a classical case of multiple myeloma. Now, briefly, how we treat multiple myeloma is with a combination of drugs, combination chemotherapy. We don't give single agent. We give at least 2 or 3 drugs depending on their fitness, and then we plan transplant and other things. A brief word about the natural history of myeloma. So usually it starts with a monoclonal gammopathy of undetermined significance, which may not be detected. And I should also put a word that a large number of youngest patients don't transform into myeloma and they die of old age. It's a small number of youngest patients transform into smoldering myeloma. When I say smoldering myeloma, they have some changes of myeloma, but they don't have the myeloma related damage. I mean, in MBBS textbooks, we have read about CRAB criteria, which is hypercalcemia, anemia, kidney damage, renal impairment, and bony lesions. So patients who do not have the end organ damage, we call them smoldering myeloma. And sometimes we don't treat them, we just observe them. Because sometimes they go on like that for many years. And the thinking is, why do you want to give chemotherapy for an elderly individual who does not have any problem? We can just monitor. So then they get active myeloma, we treat. And myeloma is an incurable cancer. But younger patients, when I say younger patients, under 70, they live for 10 years plus. And younger patients live almost 5-6 years. So, and many of them have a good quality of life during treatment because most of the myeloma treatment is outpatient and day care, because they come to day care, have a subcutaneous injection once in a week and go, and then take tablets and can live a near normal life, of course, with some restrictions like infection control and other things. But eventually the diseases relapse, then we treat, and after 3, 4, or 5 relapses, then it becomes incurable. So it's an incurable disease, but we have very good drugs to keep it under control, going to a remission. Now, how we treat myeloma is, first we think whether the patient is fit for a stem cell transplant. If they are fit for stem cell transplant, we give intensive treatment. Again, intensive treatment is mainly outpatient, not admission. And then we admit for a stem cell transplant, and then we give maintenance tablets. So they can go for many years, 4 or 5 years, without a relapse, and do really well with a reasonably good quality of life. Now, if they're elderly patients or have other comorbidities, then sometimes we don't do transplant. We just give some treatment and then put them on maintenance. I recently transplanted a 72-year-old man. Again, I thought age was not a bar because he was a farmer. He used to walk many miles, did not have diabetes or other things which we see in older individuals. And I thought he was fit, and I could not, and he was very keen for transplant also. And I did not have any reason not to transplant. So age is not a bar, but after 70 years, we are a bit twitchy because we don't want to kill the patient. So we are very careful, but if they're fit, we will go ahead for 70, 72. But I suppose after that, we won't. Now, this is just to mention combination treatment. When I say, the second BTD and all, that means there are 3 drugs there: bortezomib, thalidomide, dexamethasone. So it's just to tell about a combination treatment rather than one drug. We give sometimes a triplets, which is three drugs, or doublets, which are 2 drugs to take the patient in regimen, depending on the fitness, and also depending on the pocket of the patient also, because drugs like daratumumab is very costly. So if they got insurance, fine, we can do that. or if they can afford it. Otherwise, the other drugs are good enough. Then once we take the patient into remission, we consolidate with the stem cell transplant. So transplant, autologous stem cell transplant is basically transplant with the patient's own stem cells. Because a lot of people ask me, okay, transplant, surgery, what are you going to do? I am tempted to sell, okay, surgery. So that's something like that. What we do is, this machine is it's like a dialysis procedure. So autologous transplant means patients, once the patient has gone into remission, we give some medicines to release the stem cells into the blood. After 3-4 days, we give these medicines. They're basically injections. Once the stem cells are released into the blood, using this machine, just like a dialysis procedure, we collect the stem cells. For things like myeloma, the chemotherapy is only for 1 day. So sometimes we don't freeze the stem cells, we give the chemotherapy after collecting stem cells. So we make sure that we have collected adequate stem cells, at least 2 million stem cells. And then we give the chemotherapy, and then 24 hours after the chemotherapy is removed from the body, we give the stem cells back to the patient. So the question is, why are you doing that? So the purpose of the autologous stem cell transplant is to give a very high dose chemotherapy. So when you give such a high dose chemotherapy, it kills the remaining cancer cells, and also that will damage the patient's stem cells, and then the patients will become neutropenic and they will die of sepsis. Basically, you are killing stem cells, gut cells, everything you are killing with that much high dose chemotherapy. So then we have to rescue the patient. So this is basically a very high dose chemotherapy followed by rescue. So we are collecting the patient's stem cells beforehand, then giving the high dose chemotherapy, and then we are rescuing the patient with the stem cells. And then for the next 2 weeks, the patient will be in an isolation facility where we use what is called a HEPA filter, where even the fungal spores are filtered so that they don't get any sepsis. But invariably they will get a fever because bacteria is everywhere. Their own gut will have bacteria. So sometimes they get, usually they get what is called mucositis. What it means is, because of the high dose chemotherapy, the lining cells in the gut will die, and because of that, they will get diarrhea, and the bacteria in the gut will go into the bloodstream. So we have to give antibiotics. The main problem I am facing in India, which I did not have in UK, is multi-drug resistant organisms. So we have got some organisms where whatever antibiotic we use, they are resistant, and then we are using high-end antibiotics, and the cost of treatment goes up significantly. So to summarize, for some of the transplants like lymphoma, where we have to give 6 days of chemotherapy, the stem cells that we collected, we cryopreserve. So, this was something that my team started in Mangalore. We cryopreserve stem cells and are able to offer stem cell transplants. Now, because of the COVID pandemic, I have not been able to do large numbers of transplants. We have done around 10-11 transplants, and all of them have survived. So it has been successful transplants. So again, we have to remember that the myeloma, we are doing the transplant for depth of response and to make sure that the patient relapses later rather than early. And lymphoma, we are trying to cure the patients with the relapsed lymphoma. So I will take questions about transplant at the end. I have not mentioned about allogenic transplant because that is a separate thing by itself. This is about autologous transplant, where we transplant patient's own stem cells. Allogenic transplant is a transplant of a donor stem cells. Now, because of the, do we have time? So I'll just mention another case. So this is again patient, young lady who came in with quite extensive bleeding from the mouth, blood blisters in the mouth, petechiae, extensive bruises all over the body, anemia, and platelet count of only 4,000. Now liver function, kidney function, everything was normal. Now generally there is a tendency when there's a low platelets comes as an emergency. We start with steroid. This patient was given methylprednisolone. I think starting steroid is a right decision because mostly ITP or immune thrombocytopenia is very common, provided we exclude other causes of low platelets. Now, on the second day, again, there was no improvement. Platelets were going down, and the hemoglobin was going down. Patient was bleeding, was transfused blood and platelets, and then the patient had headache, and CT scan showed a subdural bleed. Now, at the time, I had the referral because then it became quite complicated. Usually, I get referrals once it gets a bit complicated with these sort of scenarios where the platelets are low, patient has got bleeding, and here there's a bleed into the head. So this patient peripheral smear was normal. There was no lymphadenopathy, there was no splenomegaly, because first thing I think is it leukemia? Is it lymphoma? What is the reason for the low platelet? And basically my mental algorithm is like this. Low platelet means, is it because of a low production in the bone marrow, or is it because of consumption elsewhere? So these are the two things I think first. And then the tests I do are to exclude one by one the causes of low production. And then if we don't get anything, then we think it's an immune thrombocytopenia. So it's a disease of exclusion. Now one can say that we don't really have to do bone marrow for younger individuals. It's more for the older individuals. If somebody is coming with a recent viral infection, low platelets, and liver, kidney, everything is normal, no circulating blast cells, no lymph nodes, nothing, then I think it is reasonable to give a trial of steroids to see whether the patient responds. So now what is interesting in this patient is patient has had bleed in the head. So this is a life-threatening disease. So this patient can die. So we don't have time. So when we give steroids, as many of my physician colleagues here would have noticed that it's a slow process. Sometimes it may take up to a week for ITPs to respond. So we give what is called IV immunoglobulin. And IV immunoglobulin, we don't normally give because of the cost. Because for a patient, it may cost like 1.5 to 2 lakh rupees for 2 days treatment. But here it's a life-threatening thing. So we have to give, we have to counsel the patient and then say, it's a bleed in the head. So we give. The neurosurgeons decided not to operate because there was no midline shift and it was a small bleed. And the patient responded after 48 hours and recovered. We also gave steroids. And then one of the things I do is I give some steroid sparing agents so that I can wean down the steroids easily to avoid steroid-related side effect. Now the question here is, should we do a bone marrow biopsy or should we not do a bone marrow biopsy? Older patients who are 60, 70, who come in with a thrombocytopenia, I generally tend to do a bone marrow because it can be a cancer or myelodysplasia, or these things are more common in older individuals. Younger individuals, often I do a trial of steroids. And the other thing is that generally many patients, when I suggest bone marrow, first thing they will say is Vanda. So we give a trial of steroids. And IV immunoglobulin, if it is unresponsive to steroids, if they can afford it, or life or limb-threatening bleed. And generally the bleeding will stop before the platelet count rises. That is the observation. Generally when you give steroids, the first thing that happens is the bleeding stops. The platelet count will remain same and it takes some time to rise. Now, one of the things my colleagues would have noticed is these platelets will go up, down, and often it becomes a headache for the doctor because after some time they'll come in, platelet count is still 20,000, 30,000. They're not bleeding. The patient is well, but the platelet count is low. So this is persistent ITP. If somebody has got a persistent ITP, then I will do a bone marrow because we don't want to miss something else. And then we had some steroid sparing therapy because you can't really keep on giving steroids because of all the side effects. They will gain weight, all the Cushingoid facies, diabetes, hypertension, osteoporosis, all these problems. And there's a drug called rituximab, which is a monoclonal antibody. It can work for some patients. And also there are drugs called TPO agonists, which basically means drugs that will stimulate the bone marrow to produce platelets. They're expensive, but they're available. If they can afford it, then that is fine. Then last but not the least, there is splenectomy, but it is rarely done these days. I mentioned about steroid sparing agents. As you all know, it is azathioprine, mycophenolate, and hydroxychloroquine. Generally, I try the first one or two. In the UK, we were using mycophenolate, but azathioprine is cheaper. So in India, we use azathioprine more commonly. Sometimes I add a second drug. Sometimes patient on mycophenolate, I may add hydroxychloroquine also along with that. Now, other thing is that we have to exclude SLE and other things also in these sort of patients because particularly if they got some joint pain, rash or something like that, and generally female also it's more common. So if they got an SLE, it's called a secondary ITP, and then often the rheumatologist manages and you work in conjunction. I mentioned about rituximab. Now, as you know, we got in our lymphocytes, there are what is called the B lymphocytes. And one of the markers of the B lymphocyte is this thing called CD20. So this will go and attack the CD20 and remove the B cells. Now, so thereby you are removing the antibodies that are removing the platelets. So platelets will come up. So it is costly, but not that costly in the sense that it is 15,000 per week for 4 weeks. So around 60,000. So costly, but not that costly. So depending on the affordability. And only thing is because we are removing the B cells, risk of infection goes up. So they have to be put on Ceptran and acyclovir prophylaxis. Now, these are romiplostim is what is called a TPO agonist, basically something to stimulate the bone marrow. Now, these are very good drugs. Romiplostim is the injection given once a week, and there is another drug called L-Thrombopac. This is a tablet that's taken daily. Both are very good drugs to raise the platelet. The only problem is the cost. So many of our patients cannot afford. Romiplostim is 3,000 per week. So monthly cost is 12,000. So for the poor patient, it is not possible. For the upper middle class and richer patient, you can give. L-Thrombopac is also similar cost, but some of the cheaper brands are not available now. So it's much costlier now. It's like 40,000-50,000 rupees per month. So something that even the sort of middle class can't afford. So generally, I tend to give romiplostim injection. It's 12,000 per month, so a bit more affordable but costly. Now, I'll just tell one last case because everybody is hungry and tired. Now, sometimes some patients are labeled ITP because of low platelets, and they get all these sort of treatments. So I had a 16-year-old boy who had all the treatment for ITP. Now, it was very perplexing for me because he's not responding to anything. And I was like, why is he not responding? And when we look at the peripheral smear, there are giant platelets. So what happens here is the automated machine reads these platelets as red cells. Okay. So the platelet count is artificially given as low because the machine thinks it is red cells. So this has to be manually estimated. And this is sort of like an inherited anomaly actually. So because of a genetic problem, but they don't bleed. Their manual platelet count is around 60, 70,000. Generally, you don't have to read them. They're okay. So this is my last case. I've taken a lot of your time and thank you for the patient listening. If you have any questions, please feel free to ask me.
Thank you, Dr. Rajesh. Very enjoyable talk.
All the time it is not possible, but it's a difficult case. If the diagnosis is not there,
It calls for a bone marrow transplantation.
so in other hospital, because it's a neurology hospital, the myeloma transplants are around the 4 lakh rupees. For the oncologist transplant. Lymphoma is around 5 lakhs. Saying that, I think sometimes it goes easy, like we can do myeloma for 3.5 and lymphoma for 4.5. But if the patient gets like a multi-drug resistant infection, it can go up. So, see, out of my 11 transplants, one lady developed a pan-resistant bacteria. So, we were giving her 5-6 antibiotics and labs, everything, and the bill went to 8 lakhs because of the antibiotics. So, we are not doing it as a package. It's a rough cost. So, I think we are cheaper transplant centers in India. I think probably the cheapest in Karnataka. In the private sector, we are one of the cheapest transplant centers. With regard to allogeneic, that will go from 10 lakhs plus. We are yet to start allogeneic transplant, which we hope to start this year. We have had, because I came just before COVID from UK. A lot of time in the last 2 years has been our sector was the transplant center was shut down because of the COVID. So I think doing these 11 transplants has been a big achievement as far as I am concerned, and doing them successfully.
G6PD deficiency that will show the blister sites at the right cells. To be very frank, I don't understand. We don't usually see, it's very difficult for us to see blister sites. So, what do you think is the more important thing for diagnosing or is the G6PD estimation more important?
I mean, you have to do the G6PD estimation. Yes, but PCM helps us to make a diagnosis. So, I mean, first of all, you have to look at the clinical condition of the patient. So, somebody who has got frank hematuria with a rapid drop in hemoglobin, and he has a history of some interrogate, and then classically about how the bilirubin and the classical features of the analysis, which is again outcomes negative, and then if you see these sort of cells. But you don't see features of hemolysis in the very smear. This is a very classical case. Often this is not this random. And then you also have G6PD. But many times we miss it because the patient has been transfused before G6PD estimation has been done. Estimation is essential. I agree with you.
But what I'm saying is, suppose if we don't have a clinical history and we are just taking the case, and in the case we cannot find significant blister cells, maybe some spherocytes or myeloma. So, in such cases, don't you think that PCA findings cannot be very conclusive? That's what I meant.
I mean, obviously, what you will do is you will do a direct anti-development test. It is a direct Boots test. So, Boots test is positive, which you can get cancer, or even you will get anemia. it's just negative, then you have to do GCPD or paroxysmal nocturnal hemoglobin. So you have to go by clinical finding and accept that this your algorithm should be there. So obviously you have to think, I mean, if it is food scientific, obviously you will do GCPD and go with that. I'm not saying, I mean, every case will not be, will not have all the details. And then you have to do more tests. I mean, the reason for highlighting this here is this is a very classical case. And many times we don't get classical cases and it becomes a big headache, isn't it?
It will do the screening also. Screening also.
Yes, yes. Yes.
She is not able to diagnose it is not actually symptoms or not actually cell. So we can take for
Yes. But patients we estimate is not whether we have to take the other things also. Everything is clinical and at the end of the day, the clinician has to and again, for a pathologist, see what happens for a pathologist is no information is given. And you don't have any information. So it is very difficult for you to get around. I mean, the job of a pathologist is very difficult because no kind of information is given.
In your first case, the antibiotic infusion from level 2 7 people. It will be a short course of people level 7
I think that interesting that I mean, it was even a short course of antibiotics. It is a presumed diagnosis because you see, we could not do G6PD in that patient. So we stopped on the drugs and the patient input. And so I can't say I have got a clear proof there. It's a presumed. The patient input, then we say, okay, that was the cause.
Usually, one look for the hemoglobin level to be start of the antibiotic and just 5 or 7 days. And maybe some of those also.
That is possible. Sometimes the patient may have blood also. And we are giving antibiotics to thousands of patients. This happens so rarely. I just found it interesting because there are a lot of biceps in the peripheral system. And in India, when you look at nothing in the peripheral system, the 90% of the peripheral system we look at are like the normal peripheral system. Normal, when I say normal, anemia is there, but don't say anemia can grow interesting features. It's just a dull peripheral system.
Actually, we do a lot of other tests also, but you have to do a safe one. It is production level is okay. It is serious on the bottom. Then comes the LDS, bilirubin, and all those. And we know that it is something, some antibody mediated. And it's a thing. And shortage
very detailed it's a multi-specialty. So, all these things are conjunction. I mean, reticulocyte is a very important test because not just to look for hemolysis, I use it to look at the bone marrow function also. Sometimes the bone marrow is not working properly, the reticulocyte count is low. So there are a lot of other uses for the reticulocyte.
We see a lot of other cases like PDPA-induced platelet restriction. Patient comes with low thrombocytic weakness, no history of any bleeding manifestation. Usually from the victim, steroids. Something written and proven that the hemoglobin addition of platelet comes in. That's not send for a cigarette sample for a finger stick scale. Then we get the diagnosis. So many cases are and then GPP case also, you have contribution, presentation, then fortunately we could diagnose and patient was taken for password. Like was said, there was no password presence, more than 70% mortality
Because sometimes we see that also. Actually, we are not yes, I am recently. Patient number very after process was so kicking also that maybe we should have 2 days earlier. Because it's a condition that is a very normal.
No more questions. I invite Dr. Krishna sir to present a manager.
Good evening, all. I think this talk took us to our old second year MBBS stage where we learn clinical pathology. And I express my sincere gratitude on behalf of IMI Kannur to Dr. Rajesh Krishna. Thank you, sir, for accepting our invitation. It was an excellent talk. Thank you all for attending this meeting.